So my name is Paresh Dandona. I'm the head of diabetes, endocrinology, and metabolism at the State University of New York at Buffalo, and a SUNY distinguished professor. I have major interests in the area of diabetes and in the area of male hypogonadal state, and also the action of testosterone and its various biological effects. This evening, we're going to be talking about the fact that finally an oral testosterone replacement therapy is available, and the name of this preparation is Jatenzo, which has been manufactured by the Clarus. Now, this program is presented on behalf of Clarus Therapeutics, and the information presented is consistent with FDA guidelines. This is a professional, non-CME program for healthcare professionals only. This presentation contains information about Jatenzo for appropriate male patients with hypogonadism. This program does not provide medical advice for any particular patient, which of course has to be based on clinical decisions. On to the product indication now. Jatenzo, which is testosterone and decanoate, contained in capsules, is an androgen indicated for testosterone replacement therapy in adult males or conditions associated with a deficiency or absence of endogenous testosterone. Primary hypogonadism, which is one of the major causes of the hypogonadal state, congenital or acquired, can be due to testicular failure due to cryptorchidism. In other words, there are no testicles in the scrotum, bilateral torsion of the testicles, bilateral orchitis, vanishing testicular syndrome, orchidectomy, i.e. surgical removal of testicles for some pathological reason, the Klinefelter syndrome, which is a congenital chromosome-based abnormality, chemotherapy, or toxic damage from alcohol or heavy metals. These men usually have low testosterone concentrations, and gonadotropins are above the normal range. So the two gonadotropins we are talking about are the follicle stimulating hormone, FSH, and the luteinizing hormone, LH. And then you have the other state, the hypogonadotropic hypogonadism, which can also be congenital or acquired. And in this condition, the gonadotropins, FSH and LH, are either suppressed or in the normal range. And the deficiency is primarily in the pituitary or in the hypothalamus. And it can be due to trauma, tumors, radiations, or other metabolic reasons. These men have low serum testosterone concentrations which are low, and of course, gonadotropins, as I mentioned, are also either low or in the low normal range. So the major limitation for the use of Jatenzo is that we have no information yet on boys younger than 18 years. So there is no indication for the use of this product in that age group. There is a warning suggesting that this preparation may cause increase in blood pressure. So Jatenzo can cause blood pressure increases that can increase the risk of major adverse cardiovascular events, including non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. So all three elements of MACE are involved in this risk. Before initiating Jatenzo, consider the patient's baseline cardiovascular risk factors and ensure blood pressure is adequately controlled. It's an obvious thing to do in view of my previous statement. Periodically monitor for and treat new onset hypertension if it occurs, or exacerbations of pre-existing hypertension if it is already there, and reevaluate the benefits of Jatenzo and keep an eye on that issue of cardiovascular risk. Due to this risk, Jatenzo only for the treatment of men with hypogonadal conditions associated with structural or genetic etiologies. Further important safety information is associated with certain contraindications. And in men with carcinoma of the breast on known suspected carcinoma of the prostate in women who are pregnant, in men with a known hypersensitivity to Getenza or its ingredients, or in men with hypogonadal conditions that are not associated with structural or genetic etiologies of Getenza. And since Getenza has not been investigated in these conditions. Now, a repeat of what we've said already, Getenza can increase blood pressure, and therefore it can increase the risk of major adverse cardiovascular events, and therefore something that has to be kept in mind, and we have to pay attention to that. Lastly on this slide, and that's a very important issue, polycythemia may require a lower dose of administration of Getenza, and therefore we have to check the hematocrit prior to initiation of therapy in every patient and at every 3 months, because an increase in hematocrit is a reasonably common association or complication of testosterone therapy of any kind. And this is something that has to be kept in mind. And if the hematocrit goes beyond a certain critical limit, there is no question of continuing Getenza even at a small dose till the hematocrit returns to a normal level.
So now, we need to talk about clinical hypogonadism, the challenges of developing a safe and effective oral testosterone replacement therapy, the Getenza clinical study results, and then how to individualize the dose. So here we are with a bust of the great man Aristotle, who, as you know, was a tutor to Alexander the Great in Macedonia, and of course has attributions of all kinds. And of course, amongst them, he was the first one to document the effects of castration in writing. So he wrote about it. And of course, his writings are profound and prolific, but part of it was this. So I think it's nice to know that he was the first guy one of the first guys to describe this syndrome of castration and what followed castration in terms of clinical symptomatology. And then you have on the right, you have the picture of Alessandro Breschi, and he was the last castrato. So he was one of the last ones with castration, but remember that castration in various communities around the world is not uncommon. And so it continues, and those persons who've been castrated for whatever reason will suffer from lack of testosterone, and we'll discuss the clinical symptomatology in a moment, and we'll talk about that. And both of these syndromes, my group were responsible for describing for the first time. So 1/3 of diabetics and 1/4 of all obese are hypogonadal, and they have secondary hypogonadism. And then, of course, head trauma is another condition where hypogonadism occurs. So having discussed the causes, let's then move on to the next bit, which is the diagnosis. And of course, diagnosis-wise, we measure total testosterone, which is the simplest test and dependable test. And the Endocrine Society has set the low limit of normal testosterone to be at 300 nanograms per deciliter. So anything less than 300 nanograms per deciliter will tend to be called hypogonadal state. And then with it, if LH and FSH are elevated, it's primary hypogonadism. If LH and FSH are suppressed, then it's secondary hypogonadism. And of course, that observation, the symptomatology, loss of muscle, loss of strength, lack of energy, and sleepiness during the day are all features of the hypogonadal state. So something to keep in mind, and they'll help you to make the clinical diagnosis, which then will allow you to make the overall diagnosis along with the low testosterone. And then effective oral formulations in the past have been elusive. And the very first attempt was made by the great Brown-Séquard, who was actually a neurologist. And those of you who are interested in neurology might remember the Brown-Séquard syndrome. And he was a Parisian physician in the Victorian era, 1850s. And he not only described the Brown-Séquard syndrome, which is hemisection of the spinal cord, he also defined for the first time the state of hypogonadism as being attributable to testicular disease, and he prepared testicular extracts from chickens to administer to hypogonadal patients. So his was the first attempt to create a testosterone preparation which would be orally administrable. And then, of course, it was in 1930s that the so-called male hormone that Brown-Séquard was talking about from the testicles of the chickens was identified as being testosterone, and it led to a Nobel Prize. And then we move on to the 1930s to 2019, where various testosterone preparations were tried and used for treatment. So now, many testosterone replacement methods have been developed, as we mentioned. So between 1930s and 40s, parenteral route with subcutaneous pellets, then the chemically modified methyl testosterone that I mentioned, which gets absorbed from the gut, but unfortunately, it arrives in very high concentrations in the liver, and therefore it led to hepatotoxicity. So this is a very important issue whenever you think of oral testosterone. And of course, therefore, this preparation fell out of favor. And then we are on to topical gels and patches. And then, of course, the most popular, commonly used preparations are the injections. And now with the injections, the implants. So you can implant somebody with some testosterone, a pellet that lasts about 3 months, and you'll have to put in another pellet at 3 months, whereas otherwise injections are given every 2 weeks to maintain testosterone levels in the physiological range. So now we are on to various preparations that are available that I mentioned, and of course you have injection of pain. With injections you're paying, and then you have drying time or mess with the topical stuff. You have transference to women through contact or transference to children, and then there's the issue of other problems. And if you have intranasal testosterone, you've got nasal irritation. So with these sort of disadvantages and advantages, if you like, so it's finally here, the first and only FDA-approved oral testosterone undecanoate, and easy to call it TU. And let's proceed with the data further on. So this TU, also called Jatenzo, commercially, the proprietary name, gets taken orally and then gets absorbed in the intestine, and here it is interacting with the intestinal lining, the cell, the intestinal epithelium, and while in the epithelium, it undergoes certain changes, and it gets incorporated. Just 1 minute, I missed that slide. So you can see the testosterone molecule, you can see that steroid ring being taken up and being bound to a fatty acid to become a part of a lipid particle. And being bound to this lipid particle, this particular molecule then is able to get absorbed by the lymphatics rather than by the portal channels. And since it's in the lymphatics and not in the portal channels, is then able to bypass entry into the liver. So that's a very important part of the TU story or Jatenzo story. And you can see now these molecules, these particles being taken up by the lymphatics. So those channels that you see, linear channels, are lymphatics. And they are flowing through the lymphatics, and they then get eventually into the systemic circulation. And in the systemic channel circulation, then these particles get broken down, and the testosterone TU undecanoate gets liberated. and is now available to various tissues for use by binding to, by entering cells and binding to the androgen receptor and exerting its biological effect. Now, the study that was carried out, the phase 3 multicenter randomized open-label activator active comparator trial, and the comparator was a topical testosterone ointment, and the trial was given the name INTUNE, so it's easy to remember. So TU, INTUNE. And what we are looking at here in this diagram is that patients, about 166 patients in the Jatenzo arm, got given this tablet of Jatenzo through 37 milligrams twice a day, in the morning and in the evening, and were compared with the topical administration with 60 milligrams of the topical testosterone ointment, and the comparisons were made in terms of the concentrations achieved and, of course, the symptomatology and so on and so forth. So let's move on to see what happened. So basically, you can see in the demographics that the Jatenzo group of patients, mean age 51, topical testosterone, mean age 53, very similar, and the distribution in the population, and of course, as usual, was the Caucasian population, which was the dominant one, comprising about 3 out of 4 patients, and then African Americans next and the Asians next. But be that as it may, they're equal on both sides. The other thing I'd like you to notice is that the main BMI is 30 plus, i.e. the mean BMI is in the obese range. And then the other element is that 24% to 25%, 1 in 4, were diabetics. As I mentioned, although this one says type 1 and type 2, the type 1 syndrome has rare hypogonadism unless the patient is obese, whereas the type 2 have 1 in 3 chance of being hypogonadal. So keep that in mind. And then there was a history of hypertension in approximately 50% of them. So that was the background of the hypogonadal state. And you can see that the levels are around 180 to 190, which is far lower than the lower limit of normal defined by the Endocrine Society, which is 300. So you can see 87% of patients reach the normal eugonadal range at the end of the study. And these were equal in both the Jatenza and the topical testosterone arm. So really nice sort of result, showing you a mean of around 489 in these groups, with 87% reaching the target. And then you have adverse events, and as I mentioned earlier, headache, hematocrit, hypertension, small numbers, but still it is there, and the decrease in HDL protein. And then you have nausea in some, and rashes are equal on both sides. So clearly, basically, marginal side effects, which are all sort of treatable and are easily seen, and you can deal with them. And then, change in blood pressure was noted, so increase with Jatenzo, 2.8 versus 1.8, and then ambulatory blood pressure monitoring also showed a significant increase in the Jatenzo arm. And then, well, as I mentioned earlier, those who have pre-existent hypertension also needed more careful monitoring because they were more likely to have a hypertensive side effect. And then PSA measurements. So now we are on to PSA as a marker of prostatic carcinoma. So we are seeing here that it's a marginal increase in both elements, and I can tell you that in our previous work, our own work, basically the hypogonadal patient has subnormal PSA, and with testosterone treatment, it reaches the normal range, which is about what it is doing here. And very rarely do you see a marked excess of PSA that would scare you and will have you sort of refer your patient to the urologist for the possibility of prostatic carcinoma. So now we are on to the dose adjustment, and you have these various denominations in terms of the size of the pill, in terms of testosterone levels, and you can see that the highest dose can take you up to 396 milligrams, 396 milligrams twice a day, and then you can do 316, you can do 237, and 198 and 158. But the starting dose is in the middle, 237 milligrams twice a day, and you can see that that's the dose that they started the trial as well. The InTune trial was done with that, and they achieved reasonable concentrations. But clearly, when you treat somebody, you need to titrate to the right level so that you're achieving the right plasma concentrations, and that will take care of the clinical situation and the symptomatology. Let's then go ahead with this slide that I was talking about. So if you have an excess, you titrate down, and if you have a concentration which is not adequate, you titrate up. So it is showing you nicely in this slide that you need to measure the concentrations and then to respond in the right way. And then, of course, this is a part of the sales pitch, if you like, to let you know that savings are being offered by the company, Clarus, in terms of Jotenzo, and it is possible that the commercial insurance patients may pay as little as nothing. But again, it entirely depends on the insurance company and what the co-pays are. And then, of course, the oral option. The patients have never had an oral option, which was safe since the methyl testosterone days, which was causing hepatotoxicity. But now you have an oral option, so you can sort of prescribe it. And then, of course, as against the oral option, you've got the injections, you've got the creams and the ointments, and of course, it entirely depends on the patient as to what choice he makes. But again, an emphasis is made in this slide that if you use Jotenzo, it is possible that there may be no copay in these patients.
Then further warnings. Some studies, but not all, have shown an increased risk of major adverse cardiovascular events, MACE, as we've discussed till now, and this issue has to be kept in mind. And, of course, in view of what we've said previously as well, that patients have to be monitored for benign prostatic hyperplasia, quite apart from the issue of carcinoma of the prostate. And this is something to keep in mind, and you may need to refer patients to urologists where this problem arises. Then, post-marketing reports of venous thromboembolic events, including deep vein thrombosis and pulmonary embolism, have been reported in patients with using testosterone replacement products like Jotenzo. So these patients have to be evaluated, and these complications have got to be kept in mind while considering continuation and persistence with this treatment. Testosterone has been subject of abuse, typically at doses higher than the recommended for approved indications, and in combination with other anabolic androgens, steroids like anabolic steroids, it has been used for muscle building, etc. And this kind of abuse, if suspected, we need to discuss this with our patients and check their testosterone concentrations and make sure that none of the complications I mentioned earlier have occurred. So these patients need to be counseled because long-term excessive testosterone can also switch off your own endogenous testosterone production, and this has to be kept in mind. Getenzo is not indicated for use in women. Large doses of androgens can suppress spermatogenesis. Next, you need to think about the fact that prolonged use of high doses of methyl testosterone, which was the original oral preparation, is associated with serious hepatic adverse events. Since methyl testosterone gets absorbed and gets into the venous circulation and through the venous circulation into the portal channels and therefore arrives directly in the liver. And that's what leads to the hepatotoxicity. In contrast, Getenzo, as I'll show you, has an alternative pathway of absorption and avoids the liver, and this leads to hepatic safety. Then, the other issue to keep in mind that androgens, including Getenzo, may promote the retention of sodium in water and therefore may cause edema with or without congestive heart failure. And this is a serious complication, and one has to keep that in mind. The administration of testosterone, including Getenzo, may cause gynecomastia. So, further important safety considerations. Testosterone may potentiate sleep apnea in some patients. It may cause serum lipid profile changes, including a suppression of HDL, which is a good lipoprotein in circulation and is cardioprotective, so that's something to keep in mind. And then use Getenzo with caution in cancer patients with hypercalcemia. Monitor serum calcium concentration regularly during treatment with Getenzo in these patients. Then androgens, including Getenzo, may decrease concentrations of thyroxine-binding globulin, resulting in decreased total T4 concentrations and an increased resin uptake of T4 and T3, and free thyroid hormone concentrations, on the other hand, will remain unchanged, and therefore it's something to be aware of that a change in the total T4, which is partly bound to the thyroid hormone binding proteins, may alter but does not really signify a change in thyroid status. Depression and suicidal ideation has been reported in patients treated with Getenzo in clinical trials. So something again to keep in mind because aggression can occur in male patients being given testosterone replacement. So this is something to be aware of. So the most common adverse events of Getenzo till now that have been seen, incidence is around 2%, headaches, increased hematocrit, which I dealt with earlier on, hypertension, and decreased HDL, and nausea are the other complications, adverse events that one needs to be aware of, and therefore warn patients if need be. And then we need to talk about certain drug interactions. So Getenzo can cause changes in insulin sensitivity or glycemic control. Androgens may decrease blood glucose and may require a decrease in the dose of anti-diabetic medications. And this is an area of interest to us because we demonstrated that testosterone sensitizes the body to insulin. Anticoagulant activity may be affected by androgens. Most frequent monitoring of international normalized ratio or INR and prothrombin time are recommended in patients taking warfarin, especially at initiation and termination of androgen therapy. Use of testosterone and corticosteroids concurrently may increase fluid retention, as we mentioned earlier on, and edema could be a complication out there, especially in patients who already have cardiac, renal, or hepatic disease. Some prescription and non-prescription analgesic cold medications contain drugs known to increase blood pressure, and concomitant use of these medications with Getenzo may lead to additional increases in blood pressure. So that then brings us to the use in specific populations, and as I mentioned earlier, it's not indicated for use in pediatric patients. So in patients with delayed puberty who are less than 18 years, this drug should not be used because it's not licensed for that use. So another issue to keep in mind, quite apart from the fact that there are no studies on pediatric age group, we need to add the fact that there have not been sufficient numbers of geriatric patients involved in controlled clinical studies utilizing Getenzo to determine whether the efficacy or safety in those over 65 years of age. So with this, I would like to close my talk. Would like to thank you for your time and attention, and remember that it's quite a common condition in endocrinology, and you've got to be aware of it. So thank you very much.